and welcome back to Atherosclerosis, the podcast series hosted by TSC Young Fellows. I'm Tatyana Storozhenko from the National Therapy Institute in Ukraine, and I will be your host for today's episode. In this episode, we are honored to welcome Professor Gemma Figtree, a leading interventional cardiologist at Royal North Shore Hospital and a professor of medicine at the University of Sydney. She is also chair of the federal government's 10-year mission for cardiovascular health and co-leads the cardiovascular theme for Sydney Health Partners. Her research integrates clinical and molecular science to uncover the underlying mechanisms that contribute to heart attack risk. In 2023, she was appointed a member of the Order of Australia for her significant contributions to cardiology. Hello, Professor Figtree, and welcome to Atherosclerosis.
It's very nice to meet you, and thank you for reaching out across the seas.
Thank you so much for being here, and on behalf of the ASC Young Fellows, I would like to thank you for accepting our invitation to this interview. To begin, we always like to bring out the person behind the science. Could you briefly introduce yourself to our listeners and tell us what drives your passion for cardiovascular medicine?
Yeah, absolutely. Look, I'm genuinely both a scientist and a clinician. My clinical day job involves looking after patients predominantly with coronary artery disease. I kind of treat acute heart attacks in the cath lab as an interventional cardiologist, and really enjoy the challenge of trying to coordinate a whole team of people to keep that person alive. But underlying our research program is really about how the disease itself is not the heart attack, it's actually the coronary disease. And this is something that I think we now need to tackle in a bit more of a clever way with new technology and new precision, so that we can actually detect and treat the coronary disease way before a heart attack. So I am, basically also a mother of two. I live in Sydney. I love surfing. I love outdoor adventures. And, I think cardiology is something that I find is a great mix of fantastic, clinical opportunities, but also many research questions that I think could have big public health impact.
Thank you for sharing that. And it's really very motivating to hear the roots of your passion. As a researcher, clinician, and leader, how do you balance these roles, and what advice would you give to early career professionals?
Yeah, I think I've always followed the things that I really love doing. I think one of the things I certainly tell my clinical fellows who are doing research is that it's very difficult to kind of go for a specific, to have a job that actually is perfect for you. You need to actually almost create that kind of job and figure out what bits you want to bring together. And it's only really been in the last 4 or 5 years that my research and my clinical side of things has really made sense from the outside as to why I do it. My most fundamental research is really molecular biology and redox signaling. And so I think, people have often looked at me in the cath lab going, what are you doing with that kind of thing? But it's really nice now to be able to try to bring that together, both from a diagnostic and a therapeutic perspective. And, certainly as you bring together diverse teams of people and try and solve big problems, I think that's really fun. And certainly as a clinician and someone that's involved with government and policy, I think one of the important roles we can play is to better help research be seen not just as an esoteric type of charitable occupation, but actually as a true solution for some of the greatest health challenges we've got on the planet. And so that's something that I think government really need to hear. And I think we need to get more co-commissioned approaches from government and industry partners to try to solve really big problems like heart attack. We've known about the cause of heart attack for a long time, and I think we still struggle with the things we know about, let alone the things we really don't know about. But if we took a more kind of NASA-style approach to heart attack prevention and thinking with innovation and new technology, I think that can be really exciting for government, but also for industry and obviously for the community and patients.
That's great advice for our young listeners, especially for those just starting out? And how do you stay inspired when research hits a plateau or takes unexpected turns?
Yes, I often think about this. I mean, one thing that I'm lucky about is that we do have, a moderately broad program of work that relates to each other. But I often feel very grateful that, when one thing's not going that well, hopefully one of the other things is going reasonably well. And we also tend to make sure that our researchers are involved in multiple different projects so that they get to have, some sense of progress in some of their projects if some aren't going so well. So that's one aspect. I think the other aspect is actually the fantastic opportunity we have as clinicians, just coming back to reality when we work with our patients. And, often if I'm having a bad day in the clinic, I've got good things on in research. And then sometimes if I'm having a bad day in the research lab, it's very nice to, to interact with amazing patients.
Thank you, Professor Figtree. It's reassuring to hear how even the most successful scientists navigate setbacks. Could you take us back to the beginning of your academic journey? Did you always know you wanted to become a physician scientist, or did your interest in research develop during your training?
Yeah, when I left school, I was really tossing up between science, teaching, and engineering. Were kind of three things other than medicine that I was thinking about. And in the end, I got some very good advice that actually, if you have the opportunity of studying medicine, you have the opportunity to do all of the above together. And I think that was one thing that was important. But the other thing that was really important was the realization that you don't have to continually be on the rat race. You don't have to continually take steps in a forward direction. I think being able to take time out and do dedicated research periods looked like it might have been sort of slowing you down in the medical pathway, but in fact it opened up all sorts of new doors that were fantastically helpful for, the way I've ended up being able to combine research and fundamental research with clinical practice. So I think the answer to that is, as I then went on, I was inspired by people around me. Interestingly, at Royal North Shore Hospital, there are amazing clinician researchers who have very deep fundamental research that goes on. And I think, have made important discoveries that have then been translated and benefit from having that interaction of basic science and clinical work happening there. So that's actually been very important to me. I think in terms of why cardiology and why cardiovascular, I was interested in endocrinology and renal, but ultimately I think cardiovascular medicine incorporates a lot of the kind of physiology aspects that I was interested in and the cell signalling components that I think was, certainly a passion for me.
And how did your experience at Oxford contribute to this decision?
Yeah, interesting question. I originally actually had the opportunity to go to the UK and London in the middle of my medical degree, where I took a year off to do an honours year in Professor Peter Collins' lab, where I was really interested in the effects of estrogen and other sex hormones on the vasculature and acute versus genomic effects of estrogen on the endothelium. And I had a really great opportunity of learning fundamental vascular biology in that process. But I then became interested in the actual signalling of that, and I came home for a period, but then was provided, an opportunity to actually have a funded scholarship on a Rhodes Scholarship to Oxford, which allowed me to really, work with some of the leaders in the field, but also have the opportunity of taking a project that was actually funded by the scholarship in terms of the consumables and the costs of the project. And that allowed me to kind of build my own story at an earlier stage than I think was usual for the time. And so my doctorate actually ended up looking at estrogen receptor genetics and, dysregulated estrogen signalling from a genetic and molecular perspective in endothelial and other cardiovascular tissue and, make some interesting kind of discoveries there that, I'm still kind of interested in. It was a really important learning experience, obviously, from a technique perspective, a scientific rigor perspective, but also just that inspiring kind of environment of, translation. And I still maintain very good relationships with my colleagues and supervisors from my time in Oxford, which was a very long time ago now. But, it's a very good place to be.
And now, given this experience, would you recommend international programs or fellowship to young physicians and researchers?
Yeah, absolutely. I mean, I think you end up a little bit out of your comfort zone for a few days, but I think most people who take the plunge, even to places where the language might be different, I think people are very welcoming. Science is actually now a language that kind of unites us in many ways. And I think for me, it's something that's had lasting impact. And as I said, more than 20 years later, I actually still have very strong relationships with the people that I worked there with and was, role models that have actually impacted the way that I combine my clinical work with my research.
I'm sure that will resonate with many early career listeners.
I should say, if anyone wants to come to Australia, we have all sorts of projects to discuss. So,
you have become a mentor and a role model to many. But looking back, were there any mentors who had a significant impact on your own academic journey?
Yeah, I mean, interestingly, Peter Collins in London was my first supervisor. And he really instilled with me a passion for loving the work you're doing, but also, I think the importance of the team side of things and looking after each other in that environment. In my time in Oxford, Keith Channon and Hugh Watkins were my main mentors there, both of them very active clinicians and researchers with, strong imaginations, but also balanced with rigour of scientific approach. And, Keith in particular has maintained, an ongoing collaborative relationship. He's a particularly good role model for me as an interventional cardiologist that really cares about atherosclerosis from a fundamental perspective as well. And I think that's something that's inspired both my own work as well as the way that I look after my, fellows and scientists that are coming through. And I think the way that Keith brought together the clinician researchers with his basic science team on regular weekly meetings and, on projects is exactly the way that my research has benefited. I have a diverse team of people that, fundamental researchers, bioinformaticians, clinicians, data scientists, and all of these guys enjoy working together and, often will pop in and say hello and do a bit of work while we're actually, in the cath lab kind of thing. So it's something that is, a cultural immersion that has had a big impact on me there. And interestingly, in terms of female role models, in interventional cardiology and in academia, it's obviously not quite as common. And in fact, in Australia, only 4% of interventional cardiologists are women. And certainly not many of those are, ongoing academic involvement. So I think that's something that I'm acutely aware of and certainly working with other women around the world to try to provide a better pathway for women interested in this space.
It's really wonderful to hear, and thank you for highlighting the importance of mentorship. As a board director of the Australian Cardiovascular Alliance, you helped guide national strategy. What would you see as the most effective ways to improve cardiovascular health at the population level?
Yeah, I think that there's obviously the traditional approach, and then I think we as researchers need to think a little bit outside the box, because I think whilst at a population level we really need to strive for equitable access to early risk factor identification and treatment to target, I think we also need to make sure that there's equitable approaches to early detection of the disease that we can actually treat. And I'm acutely aware that the majority of people in this country that are actually taking themselves for CT scans of their coronary arteries when they don't have any symptoms, and they're paying for their own scans because they believe in that being a helpful thing because their brother dropped dead or their best friend dropped dead. This is something that we need to catch up on because it's only the top echelon of the population around the world that are getting access to screening scans and actually then being able to treat their disease before a heart attack. And so a lot of my work is actually really driven by imagining a world where we actually do have a more scalable approach to screening for coronary artery disease. And I think trying to figure out how we can translate biomarkers, not just from being associated with plaque or atherosclerosis, but actually being able to be used to triage individuals into early detection of disease and treatment of the disease in a more personalised way before symptoms develop.
Lifestyle interventions are often challenging to implement, especially in at-risk or underserved population. How do we overcome barriers to behavioural changes in these groups?
This is something that we're actually working on at the Australian Cardiovascular Alliance level. We are trying to work on a community-facing dashboard of the bare minimum kind of indicators of clinical quality and outcomes across primary prevention, acute care and secondary prevention, so that we can work with communities that have got some of the worst outcomes and figure out the priorities for implementation and research to tackle those inequities. And so we want to actually see those dashboards as things that actually can be used to understand the health and economic value of shifting the dial, but also then working with community to figure out their prioritised approach to where we can actually shift it. And so that's something that, we're doing in both rural and remote Australia, as well as in some of the areas that have worse outcomes in the cities, and trying to figure out, from a community perspective, from a sporting club perspective or a council perspective, help them understand the options of where they can begin to, make changes. Obviously, from an environmental perspective, there's actually increasing recognition of some of the contributions of our environment to cardiovascular health, and that's something that some community members feel very passionate about, but also, different ways of actually raising awareness for community groups that are perhaps getting less access to the very simple approaches of early risk factor detection and management.
Thank you. It's a clear and powerful vision for population health. And we also know that this year you gave a talk at the EAC Congress in Glasgow on acute coronary syndrome in patients without standard modifiable risk factors, the so-called SMRF-less group. How can we better identify and manage these patients in clinical practice?
Yeah, it's really tricky. I mean, obviously there's people without risk factors in the community, but the real point of the SMRF-less definition is to highlight these people that have coronary artery disease in the absence of the SMRFs, so to speak, so the absence of standard modifiable risk factors. And so the point of this is really highlighting from a pragmatic perspective that we have at least 20% or so in our institute that don't have any traditional risk factors and are coming in with their first-time heart attack. They have a 50% higher chance of being dead at 30 days than individuals that do have a traditional risk factor. And so these individuals are really important. One of the main questions that's really relevant to the atherosclerotic kind of research community is how do we get better at early detection? How do we get better at understanding the mechanisms of susceptibility? But equally, the mechanisms of resilience are kind of interesting as well. So these individuals that have all of the risk factors in the world but actually don't have any coronary disease can tell us something about potential new drug targets, etc. So there's the basic science aspect, but then there's also how do you translate that into something that's actually going to help detect these individuals before their heart attack? And then there's also the clinical kind of pathways that we need to adopt for these individuals. So if they do have a heart attack or have coronary disease identified without traditional risk factors, what additional diagnostic tests do we need to be doing, and how do we potentially need to treat these individuals? At the moment, our secondary prevention guidelines recommend to be agnostic to risk factors, but in real life, these people are getting less appropriate secondary prevention medication, and that's partially mediating that worse mortality that we saw in these individuals. What we do know is that about 50 to 60% of them do have an elevated Lp(a), which could be a potential contributor. And so understanding what that means for primary prevention is really important. And then also, I think, in terms of known factors, understanding residual inflammation in these individuals is something that we can also make some progress in. And I think we all very much enjoyed Paul Ridker's opening plenary session. And I think we had a great chat actually after my presentation about how we can potentially better use markers of residual inflammation to better understand this population and ideally better detect them before their heart attack.
Thank you for highlighting this. And indeed, this is a very important and growing area of focus. And looking at the other ways to reduce cardiovascular risk, we have antioxidant therapies. You have importantly contributed to establishing the association of oxidative stress with cardiovascular risk. Are you considering the implementation of antioxidant therapies in the clinic?
Yeah, it's interesting. We haven't really found something that's suitable for translation on the therapeutic side, although I think some of the crossover between inflammation and oxidative stress means that the markers of oxidative stress are things that do improve with some of the new therapies that are potentially coming through. However, we are very interested in our laboratory at a particular marker of membrane redox stress and, in fact, caveolar redox stress. For those that know well, the challenges of oxidative signalling partly relate to the amazing compartmentalization of redox signalling. And I think the caveoli are one of my favourite little compartments where you've got over 250 different membrane proteins all kind of interacting together, of which 80% of them are actually redox modified. And I think there's also NADPH oxidase coupled to important receptors, and you've got eNOS that can become uncoupled as well. And so we have made some interesting discoveries about a particular redox modification of one of those key membrane proteins, and we actually can measure it in erythrocyte membranes, and that seems to reflect what's happening in the endothelium. And so we're looking at seeing whether or not we can use this as a marker of caveolar redox stress in cardiovascular disease that could be used to help understand some of these people that have susceptibility to coronary disease without traditional risk factors, but it also might be useful for understanding kind of vascular oxidative stress and disease activity as a kind of marker that might be synergistic with some of the other markers of inflammation and obviously dyslipidemia. And so that's something we're working on. I think we've really struggled in the past to have decent measures of oxidative stress, and that actually, imagine trying to treat hypertension without being able to measure blood pressure. It's kind of a similar kind of thing. So that's something that we're very interested in. Also, by being able to measure redox stress better, I think we can then start obviously testing some of these therapies in humans. I think one of the challenges with all of these new therapies is that our animal models are a bit of a struggle. And I think, particularly with coronary artery disease, humans are really the only animal that are susceptible to getting spontaneous plaque development and plaque rupture in their coronary arteries with acute myocardial infarction. I think there's one chimp in real life that was actually witnessed to have such a thing at post-mortem. But really, despite their LDL being 50% higher than most humans, healthy humans, chimpanzees are actually, I guess you could say, resilient, but in fact it's the humans that have become susceptible rather than that. And I think it's not just about LDL and Lp(a). There's these elements of increased immune and inflammatory response that play a key role as potentially also differences in redox responses.
Another exciting area you are working in is digital twin technology. Could you explain what a digital twin is in the context of health and how it might transfer precision medicine?
Yeah, I mean, I think I'm learning a lot on this front, and I love working with clever people in AI and bioinformatics. The digital twin concept is attractive to me because you can try to basically take all parameters except for maybe the one variable you're interested in. And if you've got a large enough data set with all of these things, you can try to actually understand how perturbing that might actually alter outcome. It's very difficult to provide a precise definition of a digital twin, but that's the approach that we are interested in taking to the BioHeart study, for instance. And we certainly with the advanced imaging components, we're able to incorporate that as well as large multi-omic data sets to try to understand why one individual might be pretty much for all intents and purposes the same, but then have differences in outcome. So, I mean, a classic example for me is, when you're looking in the cath lab, someone looks like they're pretty much the same heart attack as the guy from last night, for instance. But why one of them might actually be so susceptible to ventricular arrhythmias and others not. And that's a key element to whether you survive or not when you have a heart attack in the community. And I think this is something that we tend to be very pragmatic about. If we find it, we tend to treat a cardiac arrhythmia. But actually doing a matched approach within these large data sets to try to understand what's actually driving that susceptibility and resilience and what actually could help prevent or treat it is something that the digital twin kind of approach could help us with. And I think in cardiology, it's perfectly placed to really try to get some of these large data sets that could be used by, some of these approaches.
That sounds very promising, but I can imagine there are many challenges. And what are the main ones in bringing digital twin models into routine clinical use?
Yeah, look, I think in any of these approaches, it's trying to figure out the right question, because I think some of these, techniques and modelling approaches, whether it's digital twin or more traditional statistical approaches, it's really about trying to understand what the real clinical question is. And I think that's why we have such fun in our team, where we really try to articulate what we don't understand and then use that to drive then the approach to the analysis. And so that's where I think we've had some pretty decent success. And I think that's why having these teams where you've got clinicians that understand some aspects of the bioinformatics or analysis approach, but then obviously these teams that are continually iteratively working together to try to make sure that the models make sense and are asking an appropriate question is what's the biggest challenge, I think, because it's such a powerful approach that you could take it anywhere, but you just have to make sure that it's clinically useful.
Absolutely. It's important to understand the obstacles. And you have made an important contribution by highlighting the need to address sex and gender differences in cardiovascular research. What are the gaps we still face in understanding heart disease in women? And how can future studies better account for these differences?
Look, I think the improved phenotyping of the disease rather than just the endpoint is going to be very important in this. And I think already we've seen with coronary artery disease or heart attack that intravascular imaging initially and then, MRI and CT have really helped us understand how the coronary artery and the myocardium behave differently to help explain why the presentations are sometimes a bit different. I mean, I think the most important thing has been the continual underappreciation of how big a burden cardiovascular disease is for women. And, that's to the women themselves in the community, but also some of the kind of unconscious bias that we see in the clinical world and in the research world. I think, obviously making sure that we've got enough power in our clinical trials, both preclinical and clinical trials, to be able to make some analyses that are useful in both women and men, I think is important. And then ultimately really trying to make sure that the translational pathway is considered for both sexes and what's potentially blocking that or, providing a facilitation. So that's important. I think from the biology perspective, one of the challenges has often been the difficulty of animal models mimicking human disease full stop, let alone the complex the sex hormone environment of humans versus animals kind of thing. So, in cardiovascular disease, we also deal with the shift towards menopause and just the different cycling profiles and menopause situation of animal models compared to humans is obviously another complexity. So for me, I think the main thing is to make sure that we are inclusive of women in the design of the study, as well as the analysis approach and the statistics. And then obviously, if we see in disaggregated analyses that there's differences, taking that back to the bench is always going to be really eye-opening if there's differences in biology that are explaining some of this.
Absolutely agree. This topic is obviously important and deserves attention. And to close this part of the interview, as an editorial board member of high-impact journals, what emerging topics are the most exciting right now?
Yeah, I think that the coronary artery disease itself is actually really at the cusp of being something that we see very differently. I think being able to treat the disease as the disease and see heart attack as actually the catastrophic endpoint is something that we are beginning to see having an impact on the type of papers that are accepted. I've actually had papers that, a year ago were rejected. And then after, I think a shift in the culture towards how important the disease is itself, they're actually willing to relook at it. And this is where, if we come up with a marker that actually detects the disease in a patient that's asymptomatic, and talk about a translational pathway that's feasible. I think previously we've had people tell us, well, what's the point of having a marker that then just detects another marker, where they're actually not seeing the CT image of the disease as the disease. And I turn around and say to them, well, look, tell me what the differential diagnosis of that is. It's actually atherosclerosis in the coronary. We know that, and we know it's the biggest killer. And yes, we need clinical trials of how we're actually going to scale and make this equitable and make it impactful. But I think I think the Lancet's commission for rethinking coronary artery disease that Rasha led was really important in effectively corroborating what we're saying. I think, Steve Nichols has also played an important leadership role in this call. And then obviously, many of those that have led the CT imaging space have been important. But what's important from a biology perspective is how we link this together and how we bring the knowledge from our vascular biology into new diagnostics and therapies that actually are going to benefit from this shift in paradigm and have an impact on patient outcome. Because really, heart attacks could be seen as 100% preventable. And this is not just going to be, we know that if we actually treated risk factors 100%, we're still going to be left with, 30 or 40% of cardiovascular disease there based on the New England Journal data that was published by the Cardiovascular Outcomes Group. So I think, all of this says that we need more, but we're at the cusp of being able to do that better now that we actually have the imaging and can think in a more three-step pathway of early detection and treatment of risk factors, early detection and treatment of disease, and then hopefully not, but if we have to, obviously the best treatment of people that actually go on to have a heart attack.
And before we wrap up, we have a special section we call the Graveyard of Ideas. We believe failure is an essential but rarely discussed part of scientific growth. Could you share an idea, project, or grant that didn't work out but taught you something valuable?
Are you allowed to choose one that you've actually just rescued from the graveyard? I had one that from 20 years ago was actually part of my thesis that we've literally just pulled back out of the graveyard. I'm not sure if that counts, but this is actually to do with the stability of the estrogen receptor RNA and the role of the 3' UTR. We found some very interesting length variants in a poly A section of this that we are still exploring as to how it influences RNA stability. And I think this is something that we didn't have the technology to properly explore years ago. I think we're just losing mid there. But actually now with emerging technology, pulling that thing out of the graveyard and actually re-looking at it is actually proving to be very exciting.
And looking back on your journey, can you tell us which accomplishment you are most proud of?
Oh, gosh. Yeah, I don't know about that. I think from a policy perspective and a leadership perspective, I think being involved in getting government to see cardiovascular as an essential part of, the solution to health going forward, and investing in the mission for cardiovascular health to support all cardiovascular research in Australia was a very important leadership piece of work that I was involved in. And then following on from that, actually getting each of our state governments and national government to work towards a cardiovascular health leader research forum, where they were really committed to working with researchers to tackling cardiovascular disease in a more strategic fashion, not just treating as an esoteric kind of charitable occupation, but treating researchers as part of the army as a solution for heart disease. So that was important. I think in terms of actually scientific discoveries, certainly the establishment of the BioHeart study and a number of the findings that we've had from this has been one of the biggest efforts that I've made, and I think it's an incredibly valuable asset for lots of collaborative work, and I really, love the focus of that. But I think perhaps the most important fundamental discovery I've made was way back in about 10 or 15 years ago, where we actually identified, together with Helge Rasmussen, a single amino acid of a cysteine residue of the sodium-potassium ATPase beta-1 subunit that was mediating the redox inhibition of the sodium-potassium pump. And that was a really exciting bit of work that I think actually still has lots of implications we haven't followed through on. But it, I guess, is an example of something that, as a clinician, still doing something as fundamental as that has been really important.
Thank you very much, Professor Figtree. This was an incredible interview, and thank you for sharing your experience and time with us.
It's been my pleasure, and thank you so much for your very interesting questions and conversation.
And to our listeners, thank you for joining us. Until then, stay curious, stay inspired, and we will see you in the next episode of Atherosclerosis.